Good afternoon, everyone. I'm Peter Salovey, president of the university. Thank you for joining today's town hall meeting. I know this is a busy time for all of you. We're at the beginning of a new academic year, and the energy on our campus is rising. It's wonderful to see the activity on our sidewalks, courtyards, and other spaces. For the first time in 18 months, we're welcoming back all our students to campus, and we will be conducting in-person classes. At the same time, staff will be phasing into on-campus work. I know many of us are excited about this semester, but I also know the pandemic has affected each of us and continues to present challenges, and that you have questions about how we will conduct responsibly an in-person semester. Today, we're joined by the public health and medical experts who advise our university on our health and safety infrastructure. It's my pleasure to introduce our panelists to you. Dr. Stephanie Spangler is the University COVID-19 Coordinator and Vice Provost for Health Affairs and Academic Integrity. Dr. Nancy Brown is the Jean and David W. Wallace Dean of the Yale School of Medicine and the C.N.H. Long Professor of Internal Medicine. Dr. Albert Coe is the Department Chair and Raj and Indra Nooyi Professor of Public Health and Professor of Epidemiology and of Medicine. Professor Linda Niccolai is Professor of Epidemiology and Director of the Connecticut Emerging Infections Program and HPV Vaccine Working Group at Yale. Professor Saad Omer is the Director of the Yale Institute for Global Health, Professor of Medicine, and Susan Dwight Bliss Professor of Epidemiology of Microbial Diseases. Now, before I get to your questions, I'd like to share information with you about the meeting format. As you know, this is a town hall primarily focused on public health, and we solicited questions in advance and received over 200 of them. I will note that a few of the questions we received are about university policies that really aren't related to the public health situation. And for those questions, please direct them to your dean or your unit leaders. You can find detailed policy updates concerning COVID at covid19.yale.edu. That's COVID-19, one word, covid19.yale.edu. So today, we've organized your health-related questions so that we will get to the most frequently asked ones first in this first part of the meeting. We know that you will have more questions, some that will be informed by what we discussed today. So please use the form we've provided on the webpage to access this broadcast and ask your questions. Later in the town hall, we will address these more recently received questions. We also will collect your questions and share them with other university leaders. As always, covid19.yale.edu and the weekly newsletter from Dr. Stephanie Spangler will continue to be a good source of information for news and policy changes. A final note, this meeting is being recorded. So now let's get to your questions. First question, as I mentioned, faculty and students are returning to the classroom and staff are phasing into on-campus work. The most commonly asked question relates to our decision to bring so many people back to campus to study and work. So let me turn to Dr. Spangler. What are the public health conditions and precautions that have allowed us to do this?
Thank you very much, President Salovey. And first of all, I want to thank you, President Salovey, for inviting me and my colleagues from the Public Health Committee to join you today to speak to the Yale community and to thank the community for all they've done over the past many months to keep our campus as safe as possible. I should point out that we panelists are only 5 of the nearly 30 members of the committee who have met multiple days a week at 7 o'clock in the morning since February of 2020 to review current conditions and the latest information about the pandemic. Our committee includes experts in public health, epidemiology, medicine, nursing, statistical modeling, emergency response, environmental health and safety, hospital infection control, and many other areas. Some of our members consult regularly with state, federal, and international agencies like the CDC and the WHO. I am extremely fortunate to work with these individuals, and Yale is extremely fortunate to have them in its midst. In all of its work, the committee has really made its very top priority the health and safety of our community. That is our task, and we have stuck to it. After that, we have considered how we might use health and safety measures to support on-campus activities. To answer your question about how we're bringing so many people back to study and work now, I think it might be helpful to reflect for just a moment on our trajectory over the last year and a half. I think this will show the evolution in our understanding of COVID-19 and an expansion in our approaches to combat it. As everyone recalls, in the first days of the pandemic, we and the rest of the world had very little information and very few tools at hand. In fact, our primary tool was to severely de-densify the campus and ask people to isolate in their homes. There were no tests available, no vaccines, and few demonstrably effective treatments. Small numbers of our valiant staff, healthcare workers, environmental health and safety staff, those who kept our infrastructure intact, came to campus in layers and layers and layers of physical protection. But even as we were moving people back to their homes, there was great interest in exploring how we might safely bring back to campus activities that are key to the university's mission. The Public Health Committee determined that if we were to invite more people back to campus, we would not only require people to distance and mask, but we would need to find a way to identify infections quickly and prevent further transmission. Staff and experts came together to create a robust asymptomatic testing program, even before such programs were available elsewhere. So we layered testing and contact tracing onto masking and distancing to cautiously and gradually de-densify the campus to allow research programs and some on-campus learning to occur, all the while being on the lookout for outbreaks or deterioration in the local pandemic conditions that would signal the need to pivot back to more severe restrictions. We also learned a whole lot more about the virus over the past year and a half, both from scientific sources and national and international agencies, and also from our own experience. While we did see infections in our campus population, we had extremely little evidence that any of these were acquired in the workplace or the classroom. In fact, they were largely acquired in households and in social settings. The few potential outbreaks we identified were quickly contained. So with students and some staff testing regularly and everybody practicing our other health and safety measures, we provided a year of on-campus experience for thousands of students, faculty, researchers, and staff. So thanks to all of them. Over the past months, we have had the opportunity to add the most powerful, potent preventive tool to our toolkit, vaccination. Currently, 96% of our students and over 90% of our faculty and staff are fully vaccinated, and many others have vaccinations underway. While game-changing, our committee did not view vaccination as the sole solution, but rather as another and very powerful protective layer that would allow us to consider more on-campus activities for more members of our community. Using information about both the effectiveness of the vaccines and the emergence of the Delta variant, our modelers were back at work determining what testing schedule would work best to identify infections and prevent transmission. Our contact tracers added additional questions to their interviews to look for any on-campus activities that might pose additional risk. EHS worked with facilities to assess ventilation in all of our facilities. Our COVID review team has worked with schools and units to review planned programs and events, to add safety measures where indicated. And to make sure we could implement this very layered approach, we're adding layers, not removing them, to masking, testing, tracing, and vaccination. Most effectively for a larger population, university leaders prudently decided to sequence the return of staff in order to give each group that's repopulating our campus the opportunity to get vaccinated and acclimated to our health and safety measures. Our committee will continue to monitor the situation on a daily basis, and leaders are ready to pivot if conditions change. But for now, let me finish by restating that it's the added layers of protection that have allowed us to plan our return to campus, and it is the vigilance of our experts, my colleagues, and the continued diligence of all of you, our community, that will help us move forward together.
We also have a number of questions about vaccines and the Delta variant. and I'd like to address these to Dean Brown. So how much more contagious is the Delta variant? And are vaccines as effective against it? While we're talking about preventing the Delta variant, what about masking? What about those kinds of precautions? Is the vaccine as effective in preventing the Delta variant, and is masking as effective in preventing the spread of the Delta variant?
Thank you, President Salovey. Without vaccination, the Delta variant is about twice as infectious as the original SARS-CoV-2. But as Dr. Spengler just said, vaccines are game-changing, and vaccines are very effective against severe infection due to Delta. Studies of the Pfizer vaccine, for example, in the UK, Canada, and Israel show that the vaccine is more than 90% effective in preventing hospitalizations due to infection with either Delta or Alpha. For milder infections and asymptomatic infections, the efficacy of the vaccine against Delta is lower. It's more like 78% in the UK and as low as 64% in Israel. I've taken hope from two population studies published through the CDC in about the last week or two in the US, as they're also very reassuring about protection against serious Delta infection. One was conducted in New York, which has had an experience with COVID very similar to Connecticut, and it showed that vaccine effectiveness against hospitalizations remained stable from 92 to 95% from May until July, when Delta variant was markedly on the rise. In this particular population, about half the population received the Pfizer vaccine, 40% received Moderna, and 10% J&J. The overall effectiveness, which included those mildly symptomatic illnesses, decreased from about 92% to 80%. So that's very reassuring. In terms of masks, masks are not as effective as vaccination, but they do reduce transmission by 50 to 70%. And masks on top of vaccination are really effective in preventing spread from asymptomatic breakthrough infection. Yale's, by the way, is providing free-ply disposable masks, and our engineers at the Center for Engineering and Design have shown that these filter droplets about as well as surgical masks, and that's what we routinely wear in the healthcare setting.
Dean, a few faculty members have asked us about the risk of breakthrough infections from the Delta variant. Professor Niccolai, what causes breakthrough cases, and are breakthrough infections a sign that vaccines aren't working as well as we thought they would? And how do we limit the risk of breakthrough infections?
Sure. So breakthrough infections are not a sign that vaccines aren't working. Every day we're learning more and more about how well the vaccines are working in the real world, outside and beyond of the early clinical trials. The data coming in from our real world experience continue to give us a lot of confidence that the vaccines are able to significantly reduce infections. It is true that there is variability in reported estimates of how well the vaccines are working, but studies are consistently showing greater than 50% protection against infection, and it can be as high as 90%. We're also seeing far less transmission in communities with high vaccination rates, so this is very reassuring. But to the breakthrough question, the COVID vaccine, like all vaccines, is not 100% effective. So breakthrough cases are to be expected. The good news is that we have a lot of evidence that vaccination can make COVID a much less severe disease if people do get infected. So the effectiveness of the vaccines in people who do get the infection is over 90% against the serious complications of hospitalization and death. But because we do have some breakthrough cases, it is important to follow up on what Dr. Spengler was saying. It's important to think of vaccination as one of the many layers of protection we can use to prevent COVID. Vaccination is a very important step, perhaps the most important step, but we need to maintain vigilance, and we can increase our safety even more by continuing to wear masks indoors, even if we are vaccinated, avoiding large social gatherings, things we know, places we know where transmission occurs, and getting tested when needed.
Great. So faculty, staff, and students are all asking us about booster shots for the Pfizer or Moderna vaccines. And I can address the first question about booster shots, which is, will Yale be offering it? And the answer is yes. Yale is already offering an additional dose to those who are immunocompromised, and we will offer boosters to others when recommended by the CDC. Professor Omer, let me turn to you to address the other questions about booster shots. First, can you tell us a little bit about who needs booster shots? And second, what happens if someone is fully vaccinated with the Johnson & Johnson vaccine, but wants to get a booster shot? Can they receive boosters from Pfizer or Moderna? And how effective would that booster be?
So these are really good questions that we are hearing otherwise as well. And just to start with some context of some of the things folks may be hearing about the booster shot policy. So officials from the Department of Health and Human Services recently announced that in late September, the US government will make extra doses available, a third dose or a booster dose available for mRNA vaccines, but with a caveat, pending FDA authorization and CDC recommendation. And the reason why they announced it earlier on, the rationale that was provided was that it is to give state and local health departments and health systems, et cetera, some lead time to plan for it. While that is happening, CDC's Advisory Committee on Immunization Practices will be meeting soon. It's meeting next week, and then we'll continue to have meetings to look at the evidence of who needs specifically the boosters or additional doses. We do know that as of now, they have already recommended boosters for immunocompromised individuals. There's a specific list that is available, and that is available to physicians and providers, et cetera, as well, but also to the general public on the CDC side. For the rest, CDC Advisory Committee on Immunization Practices will be coming out with initially a framework. They have indicated that, and then a specific recommendation. So as President Salovey said, that Yale has been following CDC recommendations on vaccines, and it is expected that whenever it comes out, Yale will continue to follow these recommendations. One thing I would suggest that folks who are hearing these things do not freelance at this point, because recommendations are evolving. And that's why I took a second to take people through the process that is likely to unfold in the next few weeks. The second question is also very important about the J&J vaccines. Let me say first, it was a very smart and prudent and appropriate decision to get the vaccine, whichever vaccine was available, in spring, because in the middle of a raging pandemic, the most rational decision is to get any of the authorized vaccines. And in the trials, J&J vaccines showed promise, and actually showed pretty substantial efficacy. So, but now, as we are talking about boosters and the Delta variant and certain changes, the discussion so far has revolved around mRNA vaccines, because those were the vaccines most frequently used in the US and some of the other countries, and that's where the data are available. I do know that people are working, my colleagues are working on effectiveness and immunogenicity of J&J vaccine, and some new data came out just yesterday that showed in a relatively small study that a booster, a 6-month booster after the J&J vaccine could induce a pretty robust immune response. So the signs look good, and I expect that the CDC will come out with a recommendation for additional doses, one way or another, a recommendation dealing with the question of additional doses for those who received a J&J vaccine, and are likely to address whether that additional dose could only be a J&J vaccine or an mRNA vaccine dose. With all of these things, unless you're immunocompromised, the immediate action is to wait for the CDC recommendation. But as soon as the recommendation comes out, whatever it is to follow it.
And we will make it easy for you to follow it as well. Already planning the logistics. So there is a lot of interest in COVID and vaccines for young children. Right now, children under 12 are not eligible to receive COVID vaccines. So let me go to Dean Brown. How vulnerable are young children to the Delta variant? And are there particular risk factors that we need to be aware of? And what can you do to protect young children who, and others who, we go back to the immunocompromised as well. What do we know about the progress of the Pfizer and Moderna vaccines in receiving FDA emergency use approval for young children, children under 12 in particular?
Let me start with what we can do. The most important thing that we can do to protect our children, or in my case, my grandchild, as well as those who are immunocompromised, is be vaccinated. And as you've heard, as of yesterday, 96% of our students, 91% of our faculty, 90% of our staff have been fully vaccinated. Immunocompromised individuals, for example, those who have cancer, transplant patients, people receiving immunosuppressant drugs, can now and should receive a booster. And as boosters become available in the fall, as you've just heard, we need to get a booster. The patterns that we are seeing in areas with high rates of vaccination versus in areas of low rates of infection are very different, including about children and infection. You may have seen news stories from states like Louisiana and Texas and Florida about the number of children admitted to hospitals. We are not seeing this here. Earlier this week, I confirmed with our pediatric infectious disease specialists that we've had no increase in hospitalizations among children during the period that the Delta variant has been prevalent. For example, this week we had one child who was of vaccine eligible age in the hospital. And many of the children who test positive are asymptomatic, but are just tested as they're screened to be admitted to the hospital. In terms of vaccines for children under 12, the FDA now is in the process of looking at the correct dose. Children are not just miniature adults, and children tend to have stronger immune responses. And too strong an immune response can lead to more side effects. So those who develop vaccines have to balance the benefit and the risk. And because young children tend to have milder symptoms, we have a lower tolerance for risk. There are risk factors for more severe illness in COVID-infected children, and they are obesity, asthma, and diabetes. But again, the most important thing that we can do ourselves is be vaccinated.
Okay. I think the next question is for Dr. Ko. A number of participants in this town hall meeting would like to know about Yale's testing policy for students. Maybe you could give us an overview.
Thank you, President Salovey, for the question. And let me start off with the situation we were faced this summer and some of the guiding principles that the Public Health Committee used to design the current testing strategy. So first of all, the goal was, in addition to saving lives and preventing morbidity and mortality, was to reduce the transmission and disruptions such that the university could safely fulfill its academic mission. So that goes beyond the effects of preventing hospitalizations and death. And that said, as Dean Brown mentioned earlier, that we were confronted by a highly transmissible Delta variant, a variant which is twice as transmissible what we encountered in the previous academic year. And then thirdly, what Dr. Niccolai mentioned is that these vaccines, although they're highly effective against severe complications of COVID, the hospitalizations and the deaths, they're less effective against infection in general, and specifically for the Delta variant. So the question we were faced this summer was, with the onset of this Delta wave that we're experiencing now, whether we needed testing in addition to vaccinations and face masks, and if so, how much testing would be needed. And we were really fortunate here at Yale and privileged, I think, as a university to have a world-class group of infectious disease modelers who advised us not only during the summer, but throughout the pandemic, and informed us directly how to retool the testing program and adapt it for this particular threat of the Delta wave. And this was led by David Paul Thiel and Jason Schwartz at the Yale School of Public Health and Ed Kaplan at the Yale School of Management. And they developed mathematical models with a specific goal of identifying the profile of interventions that would be needed to reduce transmission and keep less than 5% of our student body from being infected during this semester. So with that very much defined goal, I think it's important to mention that we're in a knowledge gap or in an evidence gap, and they used conservative assumptions given the uncertainty of the evidence on Delta variants, and also about the introductions of infections that come from the general community into Yale. And some of the key findings of that, which directly informed the policy that's on our website that Dr. Spangler mentioned previously, was that vaccination coverage is a critical driver of safety. And because we have greater than 96% of our students vaccinated, that is really the major lever in the game changer in us keeping our universities safe. We do have unvaccinated students who are more susceptible to infection and pose a higher risk for transmission. And the guidance from their direct guidance from their models is to test them twice a week. The models didn't identify added value of testing vaccinated students, but given the uncertainty in the evidence and how everything is evolving during the Delta wave, the abundance of caution, given that evidence gap, was to propose or to implement weekly testing throughout the month of September for vaccinateds given the fact that we're in the peak of the Delta wave. And this would give the necessary abundance of caution, but it would also give the flexibility to calibrate and reevaluate the models and the testing strategy as we're going through this Delta wave. And currently, we're hopefully at our peak, and we'll be coming down. But it's difficult to project given the uncertainty.
Thank you, Dr. Koch. Professor Niccolai, we're getting questions on how we evaluate COVID infections among faculty, staff, students. In particular, what are we doing to identify and prevent an outbreak of infections?
Yeah, that's a great question. I hear that a lot as well. In terms of preventing outbreaks and infections among faculty and students, I think it's really important to note that since the very beginning of the pandemic, we have not seen clusters of COVID linked to classrooms, linked to faculty and students in classrooms. Nearly all clusters of infections that we've seen are linked to social gatherings off campus. That's been the predominant pattern that we've seen to date. That said, I think we are very well prepared for the possibility that there could be COVID transmission in a classroom. So one of the most effective strategies we have for preventing outbreaks, layered onto the high rates of vaccination that we've already achieved, is testing and contact tracing. And Dr. Koh has talked already about the testing program. For contact tracing, we've been doing contact tracing for the Yale community for over a year. Our protocols are well tested, well established, evidence-based, and the contact tracing team that is doing this work is now incredibly experienced. They're real experts in this work by now. And this program, we know, contributed to preventing large outbreaks last year. And we're going to continue with the program this year. We will identify all close contacts of students and faculty diagnosed with COVID. And this may include some people in the classroom. And we will then notify these contacts and give them appropriate guidance for quarantining, testing, and monitoring symptoms. In most situations, if we do detect COVID among students or faculty in a classroom, classes would not need to be moved online. But every classroom is different in terms of its size and its location and space. If we do learn about clusters in classrooms or other academic units, on top of, again, layered on top of the contact tracing that we know how to do and has proven to be effective, the Public Health Committee will work closely with deans and faculty and health and safety leaders to determine if there are extenuating circumstances. We did this last year with a tremendous amount of wonderful cooperation and success in order to determine the best course of action to prevent further spread.
Right. So we're getting many, many questions about gatherings. And Dr. Spangler, I think this one should go to you. People are really puzzled about why we would allow more people in a classroom than we would at a social gathering.
Yes, thank you, Peter. It is a very good question. And in my messages week after week, I tell people to avoid social gatherings. And at the same time, we're bringing people back into large classrooms. And it does on the surface appear to be contradictory. The simple answer, actually, Professor Niccolai helped to answer that question for me. Part of that answer comes from our experience and from also broader experience nationally, which is as we look at the positive infections we've had over the past year, right up to the present, we can often track them back to a social gathering. Now, why is that? And why does the classroom not pose the same risk? Well, put it simply, is that people engage in activities at a social gathering that you wouldn't engage in a classroom. And they're often some of the higher risk activities. So in our classrooms, we have students sitting in stationary seats. They're wearing masks. 96% or more of them have been vaccinated in our classrooms. The ventilation of the room has been checked. The duration is limited. There's not a lot of interpersonal mingling. Now, we all hope there's a day when we can mingle freely again, but quite the opposite is true of social gatherings. One, you don't know about the vaccination status of the people you're with often. Two, there's a lot of moving around, which gives a lot of opportunity for person-to-person interaction. People are eating and drinking. They're often not wearing their masks, which we learned in previously does add some protection. So that layers of protection are removed from the situation. And they generally engage in behaviors that may prolong the activity, increase the physical interactions. And so it is both theoretically and in our own experience, a higher risk situation to engage in social activities, particularly outside of your own household, with people that you're not familiar with. And we're doing our very, very best to focus all our layers of protection on the classroom, which is a very different setting.
So we also received a lot of questions about masking. And let me ask Professor Niccolai a series of those questions, and then you can kind of address them as a group. First of all, what is the reasoning behind Yale's masking mandate? And can you talk about the kinds of masks that one should wear? And then when is it actually safe to remove masks outside of your home? For example, are there times when it's okay to remove masks when you're indoors at work, by yourself, with a couple of people? When can you actually take them off?
Great questions. The short answer to the first question you asked about what is the reason behind the masking policy is because we know masks work. We have a lot of evidence now from many different types of studies showing that masks can reduce infection or transmission by up to 70%. And you may recall, in the early days of the pandemic, we really didn't know this. There was a lot of confusion about masks in the early days, but like in many areas, we gather evidence, we consider that evidence, and we act accordingly. So it's really not the case anymore that we don't know about mask wearing. So members of the Public Health Committee follow these topics very closely, and the committee is now quite confident in requiring mask use as part of a comprehensive plan to keep campus as safe as possible and open. Another reason, I'll just add quickly, another reason for the mask requirement is that it aligns with guidance from CDC. Everything we do is informed by much broader bodies of knowledge. And in late July, I believe CDC issued new guidance that everybody should wear masks indoors. And in fact, we now have, people probably know, a masking requirement for indoor public settings for the city of New Haven. So we're aligning with our local partners and national policy. In terms of types of mask, I think it's important to note that it's the proper use of masks that's really critical for them to work. So Dean Brown mentioned earlier the types of masks that are available to members of the Yale community. So from environmental health and safety, people can obtain high quality masks. And there are many different types, but I think the most important point that I can make here is to say that the best mask is the one that is worn properly and worn consistently. A mask that fits well and completely covers the nose and mouth at all times as needed. And then I think your last question was about when can you take your mask off? And this is a tricky one. There are not a lot of absolute times when it's perfectly safe to remove one's mask. It will always be safer to have a mask on. But that being said, there are some situations where it may be less risky to take off one's mask. And again, It's layering on the different things we know that work. So when people are outdoors, when people are not in crowded places, when people are away from large gatherings, it can be safer to be without a mask. And in the workplace, the important thing would be that people can maintain social distances of at least 6 feet.
Great, that's very helpful. We have tried to be data-driven in our decision-making around COVID and around our policies in particular, and to look at data every day, really. And there's a set of metrics that the Public Health Committee monitors. And Dean Brown, maybe you could tell us what are the parameters that are just most important for that committee? Is it infection rates? Is it number hospitalized? Is it the availability of ICU beds? What do these different metrics tell us, and which ones do we really pay attention to?
We measure and look at many things. In particular, we track the number of cases, but that is the number of cases on campus, in New Haven, in Connecticut, and in surrounding areas. The meaning of cases has changed, right? Because of the very high rate of vaccination on campus and in our area, many of those who test positive for COVID are, even as breakthrough infections, are asymptomatic, and the rates of hospitalization per positive test are dramatically decreased. So we also track hospitalizations as an index of severity. We track the sequences so that we can detect early if there's the emergence of a new variant, and we pay particular attention to clusters. We track virus and wastewater, but clearly, overall, I would say case numbers and hospitalization rates are the two main things that govern decisions.
So a follow-up question relates to how public health conditions inform policy recommendations. And maybe Professor Omer could take this one. What do we need? What would need to happen in public health conditions and in the progression of COVID-19 for you and other public health experts to recommend changes in Yale's health and safety policies, such as our testing and masking mandates?
Yeah, and I'll just extend what Dean Brown said, that there are multiple factors that we consider, and the kinds of things we will look at to change some of these recommendations include both the absolute prevalence of these cases and the rates of these cases in our city. For example, in Connecticut, less than 4 per 100,000 is considered a really good number. And without committing to a specific number, I'm just giving that as an example. The other thing would be the trends in cases. Like, is it going up? The first rule of combating an outbreak is try to get ahead of it. And sometimes the trends tell us to act even before the absolute numbers get there. So that the other thing would be, where the trends are, whether, especially if they're declining, that gives us comfort to sort of modify some of these recommendations and restrictions, for a lack of a better word. But what is the frequency of Yale cases and the nature of it? So whether they are infrequent and sporadic instead of outbreaks. What are the vaccination rates in New Haven? We are a university located in New Haven, and we sort of interact with our neighbors in New Haven, businesses and individuals in New Haven. So that's a consideration as well. And higher rates will impact our decision and recommendation to change some of these requirements. And then a couple of other things. What are the scientific trends in vaccine effectiveness? These data we continue to monitor against various variants. And I'm really proud to belong to this campus that has had relatively very high compliance rates with recommendations like testing, et cetera, compared to our peers. That has kept us safe as a group, as a community. And that's the other thing, that if these rates continue to be high, compliance rates continue to be high, that gives us confidence. And so that's the very reason why we meet frequently as a group. And as folks saw last year, that there were changes. So the only direction in recommendations is not just to make it more restrictive, It has been in the past, as you saw, and likely to be in the future in the other direction as well.
So I think I can take the next question, which is about our decisions concerning teaching and learning. What public health thresholds will cause Yale to move classes online? So let me just take a step back from that. I receive daily updates and advice from public health experts across our campus, including the very people that are participating today. No single public health condition changes our policies. We look at and integrate many different factors: infection rates, hospitalization numbers, vaccination rates. We also look at what the CDC is recommending, and we follow guidelines from the state of Connecticut and from federal agencies as well. As always, we will tell you when we are considering major changes or announcing major changes, and our focus really is on your health and on the broader public's health. Dr. Koh, I haven't thrown a question to you in a little bit, and our colleagues and students are asking us about our campus alert levels. They follow those levels. Right now we're at yellow, which is low to moderate risk. But then the CDC and the state put New Haven County at the red alert status, which is high risk. So what are the reasons for why New Haven is red and Yale is yellow, and how do we reconcile these different ratings?
So yes, Peter, thank you for that question. And I just be honest with you, sometimes it takes me a deep dive to understand the differences between these the metrics that are being used, the color schemes, and so forth at the different scales. But I think bottom line is that these three alert levels that you mentioned, whether it's the CDC or the Department of Public Health in the state of Connecticut or Yale, they were actually set up for distinctly separate purposes and were developed specifically to trigger prevention and control responses that are intrinsically different, and they were calibrated to the specific needs of country, state, and Yale. And in that, I think we are kind of color coded, and so we're locked into whether something's yellow or orange or red. But these three warning systems or alert systems, they're not comparable because of the differences in the desired outcomes and responses that are done. For example, the CDC uses one metric, for community level transmission, and that has a specific use to kind of guide what are the critical areas where ICUs are being overrun or hospitals are being overcrowded, or where vaccination coverage needs to be improved, or where testing protocols for high-risk settings, correctional facilities, long-term care facilities, healthcare workers, where new recommendations or responses have to be done at the country level. The Connecticut, has a different system, and it was designed in a different time. It was actually designed before the CDC system, and it was actually in July of 2020 when we were coming off the first wave. And that was actually to guide municipal level leaders to implement local responses with respect to testing, face masks, when to open up hybrid schools, gathering sizes at the municipal level. So a very different objective. And I think, the Yale alert levels, and a shout out to, people on the Public Health Committee, Sandy Bukaki, in particular comes to mind, was really tailored to the specific needs of and goals of Yale. How do we keep our classrooms open? What kind of activities can we open up safely? In general, we've used more stringent triggers and responses than that's been used in the community, whether local in New Haven or whether in the state or the CDC. We've kind of gone above the bar in terms of that stringency, and then also reflects the university's commitment to protecting lives of the people here. So I think these schemes are confusing, possibly using similar color schemes, but they mean very different things.
Right, that was very, very helpful. Professor Niccolai, we are receiving questions from students, that a few of them that are similar. Essentially, if you're fully vaccinated, but you learn that you have been directly exposed to the COVID-19 Delta variant by someone else, whether they're vaccinated or unvaccinated, what are you supposed to do?
Well, the first thing is don't panic. You will get a call from the contact tracing team and they will tell you exactly what you need to do. Again, we've been doing this for a long time. We have our systems to the point where we typically are able to notify contacts within 24 hours. And our contact tracing does not depend on the variant, whether it's the Delta variant or any other variant, it doesn't matter. We contact trace everybody equally. We do have different guidance, however, for contacts who are vaccinated and contacts who are unvaccinated. So contacts who are not vaccinated will have to quarantine for 10 days, as has always been the case, in addition to other things like getting tested. Contacts who are vaccinated do not need to quarantine. They do need to be tested 3 times within a 5-day period, and they do need to wear masks in all indoor settings to the extent possible. Again, in response to rapidly evolving situations and new evidence, these policies have just been updated and they are now reflected on all of the websites. So the detail can be found there. Again, so people who are exposed, who are vaccinated but exposed, do not need to quarantine, but they do need to test and wear a mask. More details are on the websites. And of course, everybody should always be monitoring for COVID symptoms, which are vague symptoms, very nonspecific: cough, fatigue, headache, runny nose, but people really need to be hyper alert to these symptoms and immediately call your healthcare provider or Yale Health if these symptoms develop.
Yeah. Well, I have you, well, you have the floor. We're getting a lot of questions about how this interacts with flu season, which is not that far away. And are we expecting a more severe flu season? And what can we do to minimize the risk of flu during a pandemic? And are we going to be vaccinating people against the flu again, as we typically do?
Yeah, that's the $1 million question. I don't have the answer to your first question. There's tremendous uncertainty right now about what to expect in this flu season. We really just don't know how severe it is going to be. We were fortunate last year to have had very little flu, but every flu season is different. I can answer the second part of your question, which is how do we minimize the risk of flu? The good news is that many of the things that we do to prevent COVID, like wearing masks and avoiding large gatherings, will prevent flu as well. And we still have a lot of measures in place this year. But also, like COVID, the most important thing we can do to prevent flu is get the vaccine. It's going to be important for everyone to get the vaccine as soon as possible. Yale Health is already preparing to administer vaccines as safely as possible to as many people as possible as soon as it's available. What we've really learned in the past year and a half is that the decisions that we make as individuals and as communities has a huge impact on how these viruses spread. It's so clear that our individual and collective decisions make a huge difference. So again, we are going to be asking everyone on campus to do their part and get the flu vaccine.
Great. And maybe I could go on to not a related question, but one that's also, I think, in your wheelhouse, and that concerns students, faculty, and staff who've requested exemptions from COVID vaccination. Do we have the numbers, and can you make any comments about those individuals?
We do have the numbers, as we've already heard several times on this town hall. There are many, many people paying very, very close attention to a lot of numbers, and vaccination rates and exemption rates are among that. So in the entire Yale community, about 35,000 people of faculty, staff, and students, about 3% have received exemptions for COVID vaccination for either medical or non-medical reasons. It's a little bit higher at about 5% among staff and faculty, and it's quite low. Less than 1% of our students have received an exemption. So that's the good news. We really should take a moment and applaud all of the members of our community who have been vaccinated and all of the people who've worked really hard to make that happen. It is true that the small number of people who remain unvaccinated do remain at greater risk for getting COVID and then transmitting it. There is no magic number for what number is too high or too low. There's no trigger point for where we need to be concerned. I think the message here is that more is always better. The more people that we can vaccinate, the better it will always be for our community. So we will continue to work to get as many people vaccinated as possible.
Right. So let's talk a little bit about herd immunity. As Professor Niccolai noted, there's very high vaccination rates on campus. Let's stay with students. We know it's above 96%. We're closing in on essentially everyone being vaccinated. Doesn't that mean we would have herd immunity against the Delta variant? And if so, wouldn't we be able to relax some of the public health precautions that we've taken, if not now, next semester? Let me go to Dr. Omer for this question.
Great. No, that's a very interesting question. And herd immunity is one of the benefits of vaccines. But the way it usually works is by preventing community transmission or reducing community transmission of the virus. And with the Delta, we had a lot more certainty with the previous variants that increasingly we got data from some of the studies we conducted and others conducted that there was reduction in transmission, especially in close contact situations such as households with the vaccine. Right now, it seems that while the effectiveness of the vaccine remains very high for severe outcomes such as hospitalization and death, there has been a reduction in its ability to reduce transmission. By how much, we don't know. And so that complicates the situation a little bit, adds the uncertainty in terms of the so-called indirect effects of the vaccine. Having said that, we are likely to have some impact on transmission as well as things settle down in terms of data, but perhaps not as high as against previous variants. So therefore, vaccines not only will continue to be a tool for individual protection, so we are getting fairly high individual protection by getting vaccinated, they will play a role as part of one of the layers of the things that we are instituting and have instituted, that Yale has instituted in terms of protecting the folks on campus and our students, faculty, and staff. And so therefore, rather than going after a number at this point, where we say, a single intervention reaches a certain threshold and we change our recommendations just based on that, I think the policy will reflect the more nuanced interaction with case rates and vaccination rates and so on and so forth, all sorts of other things we discussed a moment ago.
Dr. Niccolai, we received a follow-up question to your thoughts about exemptions a few minutes ago when you were giving us the numbers, and that is even those rates of exemptions, do they put the community at risk? Are any of those numbers high enough to be of concern?
Well, again, risk it's not a yes or no, right? There are gradients of risk. There's riskier and there's safer. So it's sort of where we are on that continuum. I think, again, we should be really proud of our incredibly high rates of vaccination that will provide a lot of protection to members of the community. It's a number that, again, as I said before, more is always better. So our numbers are good and we should be proud. And I think we can be confident that there is a lot of protection on campus, but we need to maintain vigilance.
Yeah. So a question that's echoed by a number of students. The Yale vaccination rates are quite high. The New Haven vaccination rates are lower than the Yale vaccination rates. So what should our students do? Should they not interact with people in New Haven?
I think that's a question for me. Is that right?
Yes, it is, Dr. Steiner. Thank you.
So as you all know, the virus doesn't respect boundaries. And as Professor Niccolai really pointed out, really we have to be, each of us, responsible not only for ourselves, but for the broader community. And before I answer the question, I do want to reflect on the fact that so many people in our community, our Yale community, have worked to make resources available to the New Haven community to help them get vaccinated, to help them get care that they need. And so it's really important that we realize we're all one, at the end of the day, all one community. That said, I'll come back to my previous, the answer to my previous question, which is that when you are going to interact particularly socially, you should be aware of the environment you're entering, whether it's New Haven or Louisiana. Be aware of the rate of infection, be aware of the vaccination rate if you can. It is, and take the protective measures that we're all taking, masking, maybe more distancing, and perhaps we're advising students that they may want to order out or pick up or have food delivered, at least in the early days of our semester, as more and more citizens of New Haven get vaccinated and as our campus settles in. That said, we want to support the New Haven community in all of its industry as well. And so we're not saying students should never shop or get their books, but just it's coming down again to the social gatherings, which, as I said before, we often can track, and Professor Niccolai knows, to a single dinner at a single restaurant where people just stayed longer, unmasked, were interacting together and with others. So it's a particular caution that they should take.
Great. We are just about out of time, but let me direct one last question to Dr. Ko. What are the chances that we could get a variant that's even more transmissible, even more virulent than the Delta variant? And how worried are we about that?
So Dr. Niccolai's mentioned $1 million question. This is probably the $1 billion question. And it's a hard one to answer. And just out of humility, I'm not sure there are many of us, and certainly not myself, that predicted that this pathogen or this virus would double its transmissibility within a year. And so the central question is, has the SARS-CoV-2 virus saturated its capacity to evolve, to generate more transmissible, more virulent, but most importantly, variants that escape the vaccine-mediated immunity? And we're certainly creating the ideal situation to test that question. By leaving large segments of the world's population go unvaccinated or partially vaccinated, and allowing transmission to go uncontrolled in many parts of the world, which generates new mutants, which we know, and we've learned this lesson over and time again, how these variants are going across borders. So I unfortunately wouldn't be surprised if we're going to encounter another variant, and especially one that escapes protection by current vaccines within the next year.
Sorry to hear that. Unfortunately, we are out of time, and I want to thank our experts who really work hard every day to protect all of our health and the health of our broader community as well. Let me thank all of you for attending the town hall and for sending your questions and ideas in advance and throughout the meeting. To students, you have my best wishes for your studies this academic year. Please stay safe, continue to do your part to safeguard the health of our community. To faculty and staff, I know some of you have been here every day throughout the pandemic, and some of you are now returning after working remotely for months. And I'm just grateful to you for everything you're doing for Yale, for our students, and I look forward to seeing you on campus. So be well, everyone, stay healthy, and take care.
Are we done?